Okay, good morning everyone, or good afternoon. Thank you all for coming. We will do today a brief overview on gastroesophageal reflux disease. I think that if I will ask each one of you if you had episodes of reflux, who will raise his hand? Exactly, so that's why we're here today. Okay, so our learning objectives for today will be just to understand a little bit. I know that most of you are not healthcare providers, and I will try to talk in a language that everyone will understand. But if you have any questions, you can just ask me, and I will be happy to answer. So we will talk a little bit about the pathophysiology, why it happens, why we have reflux disease, what are the symptoms, and different options of treatments, which as I will talk about, you will see that we have today different modalities that we can use to help patients with reflux disease. The subjects that we are going to talk about, as I said, is reflux disease and the consequences of reflux disease over the years that may be Barrett's esophagus, and I will show you exactly what it is. So what is it? Reflux disease. So the definition for us for gastroesophageal reflux disease is symptoms or complaints resulting from reflux of gastric content and gastric acid into the esophagus and the oral cavity. Now, there are symptoms that can be GI symptoms, gastrointestinal symptoms, which is the heartburn that patients may feel, but it can be also chronic cough, for example, as a manifestation for reflux disease, and nothing else except the cough. So the syndromes that may cause also injury because of reflux disease are mainly the ones that you see on the left: esophagitis, stricturing of the esophagus, and then the patient will come with complaints of dysphagia. Barrett's esophagus, it's the consequences of years of reflux disease and change in I will call it the anatomy of the cells within the esophagus, and I will show you how it looks like. And unfortunately, also adenocarcinoma of the esophagus, it's one of the, let's say, complication of long-standing reflux disease. The symptoms that patient will complain about mainly are reflux, and it can present also as chest pain syndrome, because every time that our esophagus will meet the acid coming from the stomach, it will try to use some defense mechanism to clear the esophagus, and I will show you what are those defense mechanisms. One of those defense mechanisms is contraction, and that's why patients may feel chest pain, and even we get to the ED just to rule out cardiac attack or other cardiac issues, and at the end it will be just reflux disease. But if there is something that I remember from my med school, was that at 4th year when we started to do GI, the first thing that they taught us is that from cardiac issues and gastroesophageal issues may manifest the same thing for, with pain and everything, but from cardiac disease you may die, from esophageal reflux not, so that's why first always rule out any cardiac disease if a patient comes with chest pain to you. So what are the clinical manifestations that the patients will complain about? We see it multiple times in clinic every week. The main complaint will be heartburn or regurgitation of food, or the consequences like dysphagia, for example, because of stricturing of the esophagus. It can be substernal burning. It may become worse when you change your positions, like for example lying flat. Supine positions on your back is one of the positions that we have more reflux than sitting. Or and another thing that may help us to understand that we are dealing with reflux disease is when we give the patient some kind of treatment and they feel much better right after the treatment. So what is the prevalence of reflux disease in the US? As you can see, more than 61 million people experience more than at least once a month reflux episode. 27 million around weekly episode, and up to 13 million more like daily episodes. So let's try it here. How many of you have daily episode of reflux? Okay.
With medication or without?
Exactly, that's the next question. The first question that I should ask is, how many of you takes any antacid medication? Okay, so, okay, how many of you experience every week? So the ones of one day should also raise their hand. Yeah. And once monthly? After a big meal or something? Okay. So, what is the pathophysiology? Why it happens practically? So, if you can see, take a look on this anatomy. I will show you. I will try to speak louder, okay? And I will come here. So, this is how we look like from the inside, okay? We have the mouth, esophagus. This is the stomach. And that's, here is the conjunction between the esophagus and the stomach. And we have what we call LES, which is the lower esophageal sphincter. It's a sphincter that usually needs to stay closed and really tight, that the acid and the food content will not go back into the esophagus, okay? There is one condition that we, which is physiological, when this sphincter opens without us, eating or anything else, and that is where we are belching, okay? Because we have air in the stomach and it needs to come out, so it will open and the air will come out, okay? Everyone knows that, right? Okay, so that's the first mechanism that should help us to not having esophageal reflux. Now, so that means that if we have any kind of issue with the sphincter, we may experience esophageal reflux, right? Okay, so other things, you remember that I told you that the esophagus has by itself mechanism of defense when it's exposed to acid. So those are the mechanisms. What we usually do when someone has reflux, you will have more saliva and you will start to swallow it because it lowered the acidity within the esophagus. And what will happen is that the tissue, the muscles of the esophagus will start to contract, okay, when acid comes up into the esophagus. So the contraction, think about that, it's like food, okay? We eat, the esophagus contract and the food goes down into the stomach. So it's the same thing. There is a continent within the esophagus that should not be there, and now the esophagus is contracting to clear the acid back into the stomach, okay? And by contraction, it's also open the LES, which helps us to clear whatever we have within the esophagus. There are other mechanisms that comes within the stomach. For example, we have, as you know, when we eat, a lot of bile is being secreted by the gallbladder and the liver to help us to digest mainly lipids, okay? So there is something that is being called duodenogastric reflux, which means that those fluids from the duodenum will get into the stomach. Now, stomach ambient is acid. Duodenal ambient is basic, okay? The pH is high. So that's why if we have fluids coming from the duodenum into the stomach, it will lower the pH, which means that less acidity will be in the stomach, okay? Any questions? No? Okay. So those are the mechanisms that we use to defend ourselves from the reflux. So, what are the diagnostic tests that we can use for reflux disease? So the first one, you know, if I see a 20 years old patient in at the clinic with complaints of heartburn, the first thing that I will do, most probably, if there are no alarm symptoms, and we will talk about that a little bit, I will give him just treatment and see how is he doing in 1 month, and we will go from there, okay? The main treatments we will review in a few minutes. If patient has severe reflux or is complaining on dysphagia, or the patient is with advanced age, I would say, above the age of 50, and I will show you that, or alarm symptoms, we will need to scope and do an upper endoscopy on those patients. And what we usually do when we do an upper endoscopy, you can see it up there, that's called GERD, okay? That's a real GERD when we see erythema and we see even ulcers within the esophagus due to the reflux disease, okay? So that's GERD. What are the indications? When I see a patient in clinic, I'm asking myself, what are the indications for those to perform an upper endoscopy? As you can see, the indications are mainly the complications that may occur due to the reflux, like dysphagia, odynophagia, vomiting, weight loss, anemia. All of those are alarming symptoms so that we need to consider when we think about performing an upper endoscopy. And we need to screen patients with high risk. So means if I see a 60 years old patient in the clinic that says that he has reflux for the last 30 years and whatever he's taking never helps him, and one of his parents had also esophageal cancer, that's a patient that I will not think twice before I scope him, okay? Other modalities that we can use, we don't do it a lot today, is using X-rays to help us identify GERD, and that's by contrast swallowing, as you can see, barium swallow, and we give the patient the barium, he swallow it, and then we do some X-rays and we see how the barium goes back from the stomach into the esophagus, and we can say that this patient has real reflux disease. But it does not play any role in the GERD, like in the reflux diagnosis, because that's too complicated, but there are patients that will experience reflux but has no ulcers or anything, and that is not being called GERD, like reflux disease, as I just said, okay? The consequences is what we see over there, and it helps us to rule out also any kind of cancer and take biopsies and other conditions within the esophagus. So barium swallow, right now I will use just when I have a patient that comes with complaint of dysphagia. I will do a barium swallow just to see the anatomy of the esophagus by X-ray. Any questions? Okay, so that's the main thing that we see in patients with reflux disease. It's called esophagitis, okay? And that's the ulcer and the inflammation that we see due to the reflux. We have different classifications that we can use. Of course, you don't need to remember that. There is no test after this lecture. But we can split it into 4 different grades, as you can see. And the treatment is pretty much the same. It does not change a lot, but it gives us some idea about the severity of the reflux disease, okay? If someone has a bigger ulcer, it means that he has more severe disease, okay? So, there are other tests that we can use that helps us to understand if a patient really has reflux disease, and when do we use those tests. Mainly, let's say that I had the same patient that I was talking about a few minutes before. I performed an upper endoscopy and I didn't find anything. There is no ulcers, there is no erythema, there is nothing that may show reflux disease. So then we can go into what we call physiological testing, and that's the pH monitoring. There are different ways to check for pH today. One, the older system is like a very thin catheter that we place through the nose into the esophagus. The patient goes with that home for 24 hours, and then practically he needs to register every time that he feels like reflux coming up. You have a small node and you just write it, and then we try to compare it with the actual level of acidity within the esophagus, and that's how we can identify real reflux disease without the esophagitis that I showed you, to other disorders of the esophagus that may cause feeling of reflux but not a real reflux disease, okay? So that's the catheter. Today we can do something else that it's called Bravo capsule, and it's practically when we do the upper endoscopy, we can implant a small capsule that will stay 3 centimeters above the conjunction between the stomach and the esophagus, and it will register the pH, the level of acidity within the esophagus, and we can do it today for 24, 48, or even 72 hours. So it gives us a full picture of the pH within the esophagus for a long time, and it's more comfortable for the patient because they don't have this tube that they should go home with that. And this capsule then disattached and goes out with a bowel movement. I will not talk about the impedance, but just to make you understand, we have systems that we can, not all reflux disease or reflux symptoms are provoked by the acid. They may provoke also, you remember that I showed you the bile that comes from the stomach, from the duodenum into the stomach? The same thing. This bile can go into the esophagus and cause the same symptoms, but it's not acid. So the treatment is different. So we can check for different conditions by those devices. And the last thing is something called esophageal manometry. It's a test that gives me the, I can check for the contractility of the esophagus, okay? And patient with dysphagia, for example, that has issues with swallowing things, and we do the upper endoscopy, there is nothing there, so I can perform manometry to see if the esophagus is contracting correctly or that there is any kind of muscle disorder that may explain the dysphagia that the patient experienced. Okay? Questions? Yes?
On the second treatment with the capsule, did you say that it dissolves?
It's not dissolved, it is attached from the esophagus, and then you just, with your bowel movement.
Okay, and then the other is your feedback. How are you getting your readouts?
There is a recording system, yeah, for that. You should go with the recording and bring us back to us, that's it. Yeah, please, ma'am.
Yeah, could you tell me the difference between silent reflux and the heartburn reflux? I don't have the heartburn. My doctor calls it silent reflux, where I have to clear my throat a lot and limbs will come up. I mean, I'm on laser for those.
So it's pretty much the same thing, okay? Because when we eat and food goes into the stomach and goes back, it's already with acid and everything, and it will go back. So most of the times it's the same thing. I treat patients with regurgitation of food or heartburn, the same thing, okay? But I think the main thing that should be done in those situations is just what I just said, the upper endoscopy, and if there is nothing there, the manometry to check the contractility of the esophagus. The manometry?
Yeah, I don't have regurgitation of food or the heartburn.
Okay.
He just calls it silent reflux, where I have to clear my throat a lot.
Yeah, so usually when patients are complaining on cough or cleaning their throat a lot, they should go and see an ENT. They can perform a very short fiber optic and see the vocal cords, and if the vocal cords are inflamed, most probably it's related to reflux disease, yeah. Okay? Yes, please.
I was just gonna say, I suffer from GERD, and I had the same issue. It turned out I had allergies in addition to GERD.
Yeah.
And the allergies was causing, it's the postnasal drip, and that's what causes that.
Yeah, so that's why I said ENT, because those symptoms can come from postnasal drip, and that's why they can rule it out also. Okay? Okay. So, what is the long-term management of gastroesophageal reflux disease? So the goals are mainly symptom control and improvement of quality of life. Okay? We need to maintain esophageal healing. If we found that the patient has ulcers during the upper endoscopy, so we need to treat those and get mucosal healing, what we call it, and preventions of the complications that I mentioned a little bit before. So what are the choices of management that we can do? Practically, lifestyle revisions, that's the first thing, and that's what I always tell my patients in clinic, we can do a lot of things as far as medications, but if the patient will not change their life habits, that most probably will not be so effective as if we will change and will give also treatment, okay? Anti-secretory medications that I will show you a few of those, and there are also surgical and endoscopical treatments that we can give today for patients with gastroesophageal reflux disease. So what about lifestyle modifications? We mainly in clinic try to figure out which patients has habits that may provoke acid reflux. So for example, I always ask about coffee, okay? I always ask about smoking. I always ask about fatty food. What is the last time that you eat during the day, and when do you go to bed, okay? Because one of the things that we need to remember, if our stomach is full when we go to bed, okay, the pressure goes up and the sphincter that I showed you will open and you will have more reflux, okay? So that's one of the things that we need to understand. I always tell my patients to try and decrease, as I said, alcohol consumption, coffee consumption, chocolate, okay, helps to open the sphincter. So that's why you should avoid also chocolate, orange juices, tomatoes, especially in the evening time. Those are the stuff that we should avoid, okay? And then there are things that we can do even when we go to sleep. For example, elevation of the head, or even sleeping on the left side, okay? Those are things that showed that may help in decreasing the acidity within the stomach. And the most important thing is the weight. So if a patient is obese, most probably they will have reflux. And the mechanism for reflux in patients that have overweight is practically two. The first one is if a patient is overweight, the pressure within the abdomen, okay, within the belly is higher. So higher pressure will open the sphincter that I showed you, and more reflux will go, okay? More acid will go into the esophagus. The second thing is that obese patients tend to have something that we call hiatal hernia, which is a hernia of part of the stomach that goes up into the above the diaphragm. And what happens there is that it facilitates the reflux that goes from the stomach into the esophagus. And that's why weight loss is one of the most important things that we should offer patients that are obese. Yes?
What causes the esophageal hernia? I had one and I had the surgery and everything to get removed. What causes it?
So it's mainly loosening of the muscles of the diaphragm, because the diaphragm, as I showed you, the sphincter, it's not a real sphincter, but it's formed from the diaphragm, which is a muscle, okay? So if we have a loosening fibers over there, that may cause the hiatal hernia, and increased abdominal pressure due to obesity will cause the same.
Could it be caused, like, I know I would cough a lot. I guess from the acid reflux, it caused me to do a lot of coughing at night.
It may, because coughing increases the intra-abdominal pressure, so yes, it may contribute, okay? So, what about, yes, please.
Quick question on the other slide.
Yeah.
The first bullet point says that tobacco, alcohol cessation did not improve pH profile, but I thought you said that it did. So which is, I just want to...
Yeah, I will still recommend patients to do it, okay?
Okay, but
because
in the research it doesn't necessarily show.
no, it's okay. So it's showing improving of symptoms in patients, but this is talking about a real probe that stays in your esophagus checking for the pH. So we have two things here. We have the patient symptoms and the real reflux. There are a lot of people that has reflux but don't feel anything, okay? So you should remember that. There are a lot of patients that does not have reflux, like abnormal reflux, but still has the feeling of heartburn, okay? But this is too deep to get into. You're welcome. So what about pharmacological treatments that we can use? So antacid, it's over-the-counter things like Tums, okay, which is like bicarbonate that I'm sure a lot of you tried in their life because of some episodes of reflux. It gives pretty much a rapid relief, but it does not help in any way into decreasing the pH or healing the ulcers that can be seen due to the reflux. So I will not recommend someone to use it on a daily basis. If someone has, once monthly, feels some reflux after a big meal, yeah, you can use that, that's fine. But not if someone has more than every once in a while episode of reflux. Prokinetics, we don't use a lot today. It's improved the symptoms, mainly in mild episodes of reflux, but it may help just in very mild disease as far as esophagitis. So we don't tend to use it a lot. The main two drugs that we use are the H2R, those are H2 blockers, we call those, and those were pretty much the first medications that we have used for reflux disease. It's relief symptoms in about 50% of the patients. It's effective in just mild erosive esophagitis. And what we should remember is that those subjects may have tachyphylaxis. What does it mean? So when those drugs came out, all the GI physicians give them all day to all the patients. And the problem is that first our body gets used to those medications. So if I will take it once a day or twice a day for a month, it will not do the same effect in 3 months from now, okay? Because our body got used to those medications. The only thing that it was approved to, and that's what I'm doing a lot with my patients, this is a very good medication for nighttime reflux, okay? We have acid production within the stomach even when we are asleep. So that's a very good medication to suppress this kind of acid secretion. And I usually give it in alternating days. Today yes, tomorrow no, to avoid the tachyphylaxis that I just talked about, okay? So I will use this medication just if a patient has severe reflux, already taking another medication that I will show you, but still has some more reflux, I will give him that right before bedtime, okay? And the medication that we use today, it's what we call PPIs, which is proton pump inhibitors. And those medications are practically suppress the acid secretion. We have different kinds of PPIs that we can use today. All of them except for one are prodrug. So I'm sure, how many of you take this kind of medication here? Okay, ma'am, how do you take that? What do you take? Omeprazole. How do you take it? No, when do you take it? Morning. When in the morning? Breakfast time. So you eat first breakfast and then take it, or you take it and then eat breakfast? How much time before breakfast? Half hour. Why? Routine. Did anyone ever told you that that's how you should do that? Okay, so, but that's how you should do that. You should take all of those drugs on an empty stomach 30 minutes before you eat, okay? And why is that? I just said that except for one drug, that the name of this drug is Nexium, okay, or esomeprazole, all the other ones are pro-drugs, okay? So when we take them, they are not active yet. So what happens is that we take the pill on an empty stomach 30 minutes before eating. It gives the time for the liver to elaborate the medication and make it in the active form of the drug, okay? And then when we eat, we have to eat, because the eating process will activate the medication, and this medication will connect to the spot where it needs to go to and block the acid production, okay? So if you guys take any kind of PPIs except for esomeprazole or Nexium, you should take it 30 minutes on an empty stomach prior for eating, okay? And the eating is important. Yes?
Most of the things on the packaging says 2 weeks. What is the long-term side effects of taking it? From
I will touch base about the side effects and everything, okay? We will talk about that.
Okay.
Yeah.
I mean, I'm just talking about taking it, that PPI for a long period of time.
Yeah, so we have patients that take it for years, yes, but there are some I will not call it evidence, but some concern about long-term treatment with PPIs. The quality of the studies that show that there may be something are very low. It's not like, you know, following patients for 30 years and see what happens. It's just from charts of patients, from insurance companies that they try to cross-check different diseases and then said, oh, patients that take PPIs may have more of that, okay?
Follow-up question, do you ever heal
From what?
from the esophagus erosion, from the heartburn? Taking this for 2 weeks, do you ever heal to where that you can get off of it, or is it something that you have to stay on forever and ever and ever?
So that's a good question, but you never know who will be able to get off the medication and who's not, okay? And the way to do it is just by give the medication for how long your doctor thinks to, and then if you take it twice a day, to decrease to once a day and see what happens. If you still have reflux symptoms, most probably you cannot get off of that. If you stop the medication and the reflux symptoms come back, most probably you should continue with the medication, okay? So there is no, yes, if a patient, I did an upper endoscopy and there was a big ulcer and all of that, yeah, I will do another endoscopy to see if there is any kind of healing. But as far, we mainly, with reflux disease, we mainly treat the patient's symptoms more than the complications, okay? It helps us also to avoid the complications, but still, it's mainly how you feel, okay? So if you have reflux, you should take something, okay? And I will go back to the side effects of PPIs. Any other questions? Yes, ma'am.
Yes, can you explain what adenocarcinoma is?
Yeah, I will touch base on that also. Okay. Any other questions?
You mentioned Nexium as an exception,
Mm-hmm.
and I don't understand
Why?
what I'm supposed to do different, because I'm taking Nexium.
Okay, good. So whatever I just said, it's not a rule for Nexium. Nexium you can take with food because it's already a drug. So you can take it, and after a second you can eat.
Okay, so it's just the process of when you take it and how you take it.
Yes, yes. It's the difference between being the active form of the drug or to be the prodrug, what needs to be activated within the body.
Okay, got it.
Okay. Yes, ma'am.
I was taught in one of the classes that I've taken that we produce most of our acid at night when we sleep, and that we should take protein pump inhibitors before we go to bed.
That's not true. We give PPI. So first of all, 1 dose of PPIs should be fine for 24 hours. Okay, so that's usually we use once a day, but there are patients that have severe reflux, so we use it twice a day. But it's not that most of the acid that we produce. You produce acid when you start to think about eating. You produce acid when you are chewing. You produce acid when you are swallowing. You don't produce acid, you do, but not in the same quantity while you are asleep because your stomach is empty. Okay? Yes?
Very quickly, the results on the graph, are they patient reports or are they measurements of stomach acid?
Patient report. No, erosive esophagitis, it will be the EGD, the upper endoscopy. Yeah. Yes?
My question is related to the lifestyle. I usually hate to take medication because I think it's like a chemical.
Mm-hmm.
So all chemical has some side effects. So is it a healable disease or it's like lifelong disease like diabetes?
So I didn't get the last part of your question.
Is it a curable disease or it's like lifelong disease like diabetes? live with that?
So a lot of times when patient will perform the lifestyle modifications and will stick with that, a lot of the times we can deal with just with the lifestyle modifications. In the meanwhile, until you perform all the lifestyle modifications, there is a chance that you will need to take some medication. But again, it's the same issue here. If you're on medication right now, you will do the lifestyle modification. We can try and play with the dosage and the timing, alternating days, and see what happens. If you still have reflux, most probably you will need to take it. Okay? Okay. So here is about the dosing. Usually we start with 1 dose a day, okay, in the morning time. You should take it before meals, as we discussed. It's a prodrug. We should increase to twice a day if there is a response, but it's partial, or there is no response at all. So we will try to do it twice a day. We can also switch between different drugs when I think that maybe this kind, like the omeprazole, is causing some side effects or is not effective enough, so we can go higher. So higher means to go to Nexium, or even higher than that, it's called Dexalan. It's a new medication that we have. It's always a PPIs, but it seems to be stronger than the other PPIs. It's also much more expensive. So we always need to deal with cost and effective. What happens when we have a patient that does not respond to PPIs? If we thought that the patient really has reflux disease and we gave him twice a day of PPIs and maybe we gave him also the H2 blockers that I just showed you and he still has symptoms, we need to think that most probably this guy does not have reflux disease. He has symptoms from some other thing, okay? Like motility issues of the esophagus, some contractions problem of the esophagus, some clearance problems of the esophagus, and that's what's causing his sensitivity. There is also something called hypersensitive esophagus, which means that everything is fine as far as the acid, but your esophagus is too hypersensitive to the normal acid exposure. Okay? There are also diseases like that. The best response is when we have patients with erosive esophagitis, when we really saw ulcer, and most of them will heal, 90% of them will heal within 8 weeks from treatment start. So, one of the complications that we are dealing a lot with of long-standing reflux disease, it's what we call Barrett's esophagus, okay? And it's pretty much a mechanism that our body uses to defend the esophagus from the long-standing reflux, okay, and acid exposure. The cells within the esophagus are changed, okay, and they are changed in a mode that they can be, they can stay longer exposed to acid. So in theory, it's a good thing, right? Because now we have the acid, we will change the cells, and those cells will be more resistant to the acid. But the problem is that those cells, that's not the place where they should be, okay? Those cells, this kind of cells should be within the small bowel and not within the esophagus. So that's a change that we call this change intestinal, which is the small bowel, metaplasia. Those are the cells within the small bowel that appears to be within the esophagus right now because of the reflux. So that's a pre-cancer situation. It's not cancer, but it may develop into cancer with time, okay? So we can divide the Barrett's esophagus into 2 different groups. Short segment, which is less than 3 centimeters, or long segment, it's more than 3 centimeters. Up to 15% of the GERD patients will develop Barrett's esophagus, okay? Remember one thing, if we will take all the patients with Barrett's esophagus and we'll ask them about reflux symptoms, if they ever had reflux symptoms, 50% of them never had any reflux symptoms. So Barrett's esophagus can come also, that's what I said, I see your face, sir, but that's what I said. Not all, I said it at the beginning, not all patients with reflux feel the reflux, okay? That's why 50% of the patients with Barrett's esophagus did not experience daily basis reflux disease, okay? But most of the patients that will develop this kind of situation will be the ones with active reflux disease. We mainly see it in white males above the age of 50, and the risk increase if the patient had family history of Barrett's esophagus or even adenocarcinoma, cancer of the esophagus. How do we deal with Barrett's esophagus? The main treatment is again PPIs. It does not depend what is the progression of the Barrett's esophagus. We always give PPIs to patients with Barrett's esophagus. Now, when I see this kind of picture on an upper endoscopy, I will take biopsies, and the biopsies will help me first to identify that we are talking about Barrett's esophagus, because I need to see the cells under microscope and say those cells does not belong there, okay? Now, those biopsies will help me also to see if it's just what we call Barrett's esophagus with no dysplasia, or that there is dysplasia within the Barrett's esophagus. There are two kinds of dysplasia, the low-grade one and the high-grade one. Those dysplasia needs to be treated not just with PPIs, but with other equipment and procedures that we have. So those kinds of dysplasia, usually we treat with different modalities. By the way, we have everything here at South if anyone needs that. We can treat it with what we call ablation. We can ablate completely the Barrett's esophagus. Those are a few sessions that we need to do for that. While in the meanwhile, the patient will be on PPIs. If I see this kind of lesion and I see that there is a bump or a lump, okay, something raised from that changes, I can go and resect completely this area by endoscopic modalities and cause a healing of this raised area and then the ablation. So that's one treatment. We have two kinds of treatment. One is heating and the other one is cooling. We have cryotherapy, it's called, and we are using nitric oxide, and we practically cooling or freezing practically the mucosa, causing death of those cells, okay? All of those things needs to be done more than one time to be able to eliminate completely the Barrett's esophagus. If we cannot eliminate completely the Barrett's esophagus and a patient has still dysplasia, most probably this patient will go to surgery, okay? Any questions? Okay, now for the questions about the adenocarcinoma. So adenocarcinoma, it's practically cancer of the esophagus, and in the esophagus we may have two kinds of cancers. One of them is the adenocarcinoma, the other one is a squamous cell carcinoma. Those are different. The risk factors for those kind of cancer are different, and most of the adenocarcinoma of the esophagus will develop from the Barrett's esophagus, okay? So a lot of times there are patients that never had an upper endoscopy, had for years Barrett's esophagus and reflux, and at the end develop cancer of the esophagus, okay? So it's mainly cancerous. And as you can see here, the incidence of esophageal cancer is rising. If we compare, you know, the 1980s to the beginning of 2000, you can see increase of more than 400% in the incidence of adenocarcinoma of the esophagus. Now, it can be that there is some lifestyle that, you know, changed and caused more episodes of higher incidence of adenocarcinoma, but it can be also related to the fact that we are doing much more upper endoscopies, and a patient doesn't, you know, die on the street and no one knows why he died, but now we know that he has esophageal cancer, and that most probably the reason why, you know, we see much more than that. So it's pretty much both of them together that gives us the increase in the incidence of esophageal cancer. Any questions? Yes, ma'am.
Yeah, I had salivary gland cancer, adenoid.
You have what?
Well, I've been treated for
Mm-hmm.
And I was wondering if there was any timing, the sublingual, left sublingual, I mean, it was removed, and I had treatment, and then I was just being monitored.
Mm-hmm.
And I was wondering if there was any timing with the reflux.
With the other kind of cancer, not like the one that you had.
Well, just in general, because I mean, I've been on lansoprazole for, probably 10 years. And I just didn't know if reflux correlated with the development of that salivary cancer.
So it may be if the reflux was all the time, you know, around the mouth and everything and got up to there, yeah. So, you know, it's again acid, or mouth is not used to be exposed to acid for such a long time. But it's not like something that I can say, yes, there is a line between the reflux and this kind of cancer. But with the adenocarcinoma of the esophagus, yes. Okay? So, who do we need to screen? Do we need to do EGD for every patient that has reflux disease? No, just if he has alarm symptoms, as I said, or if he had family history, if he is a white male above the age of 50, and he had more than 5 years of reflux complaints. If there is a family history of Barrett's esophagus or esophageal cancer, and the patient is coming with complaints of reflux, we should think about doing an upper endoscopy on those patients. Now, let's say that we found that this patient has those changes of Barrett's esophagus. What do we need to do? So if the biopsies did not show any dysplasia, we can scope the patient again in between 3 to 5 years. I usually do it around 3 years. If we have high-grade dysplasia, we will need to do the interventions that I just described a few minutes ago. And if it's low-grade dysplasia, there are two schools for that. One is saying just follow up every 6 months, do an upper endoscopy, take biopsies, see if there is any kind of progression into high-grade dysplasia, or just treat. That's the other school. We are in the school that says just treat. Okay, it has been proven that it lower the rate of progression from lower grade dysplasia to high grade dysplasia and cancer. And it's also cost effective if you treat patients with low-grade dysplasia instead of doing an upper endoscopy every 6 months. Okay? So, that's fine. Ablation we talked about. Now, before I will end, I wanted to talk about other different modalities that we can help patients with PPIs, but before that I will go back to your questions about the side effects. So I'm sure a lot of you heard about, long-standing treatment with PPIs may cause osteoporosis, may cause kidney disease, may cause Alzheimer, may cause a lot of things. So when we see patients in clinic concerned about those kind of side effects. The main one that the two main ones that I will follow somehow will be the osteoporosis one and the kidneys. There is no evidence yet that I can say that the use of PPIs for long years may cause dementia. Okay, but I will do blood work every 6 to 9 months, checking for the calcium level, magnesium level, kidney function. Those things I will do to be able to see if we are not in any kind of deficit because of the long-standing treatment with PPIs. But yeah, for sure, we don't think right now that dementia or Alzheimer is part of the side effects of PPIs. Okay, but of course, patients does not want to be all the time on medications, or they are afraid of the side effects. So there are other modalities that may help without the need of taking medications every day. So those are the two main procedures that we can do today. That's a surgical procedure, that's an endoscopic procedure. The surgical procedure is called fundoplication, and practically what they are doing, as you can see here, they take part of the stomach, the one that is very close to the esophagus, and they wrap it around the esophagus and tie the sphincter. Okay, that's what it is. It's a surgery that being done. It's a very good surgery that being done for patients that has, oh, she left, but if a patient has hiatal hernia and reflux disease, you can repair the hiatal hernia and do the fundoplication that helps to prevent the reflux episodes, okay? The complications of this kind of procedure is always, it's a major surgery, so complications may occur. But as far as GI complaints, a lot of those patients may come with a complaint of dysphagia after they had fundoplication because it's like very tight, okay? So there is measurements that we can use to try and untight a little bit the fundoplication, but that's the main complaint that we see in the GI field of patients post Nissen fundoplication, it's called. The second one is a new technique that is being done in the last few years in the US. We are starting it right now here at South. It's called TIF, and it's being done endoscopically. Okay, and it's pretty much the same thing as the Nissen, but just endoscopically. So that's a procedure that is going to be done as an outpatient procedure. The patient will come, will get this kind of procedure, and will go home after that. And the results of this kind of procedures are exactly the same as the Nissen fundoplication or something else that I didn't bring today, but it's called links. It's some magnets that you place around the esophagus and tight this area of the sphincter. So the results of those kind of modalities, all the three of them, are pretty much the same. The difference is that the links procedure and the fundoplication are being done surgically, and that procedure is being done endoscopically. And that may help patients not to use on a daily basis PPIs. Now, the main problem with those kind of surgeries, all of them, is that the best results that you will get will be for the patients that responded well to treatment with PPIs, okay? So don't take a patient, like for example, that you gave him double dose of PPIs plus the H2 blockers and still has symptoms of reflux disease. Most probably he will stay with reflux symptoms at least, even after those kind of surgeries. Okay? Yes, please.
Sometimes, doctors say that, because of the loose, your sphincter, you might have reflux. In that case, if somebody does like high activity, like, weightlifting and stuff, does it hurt or is normal?
Does it what?
Does it hurt your sphincter or is normal?
If you do what? This kind of surgeries?
No, without surgery. Like, sometimes acid reflux comes because of the
Yes.
loose sphincter.
Mm-hmm.
So in that case, if somebody does like, high level activity, like gym and stuff, weightlifting and stuff.
No, it may even worsen it. Because when you do gym stuff and you pull weights, you increase your intra-abdominal pressure. And that may cause even worse reflux, okay? I think if someone has problems with a loose sphincter, he should get one of those, okay? Yes, ma'am.
I always have something kind of like, feel like it's stuck in my throat and I'm coughing on it. Does this have to do with?
It can be. So it can be one of those two. So that's why ENT is the first stop that you should go to. Okay? Yes, ma'am. What?
Some of the side effects from the PPIs.
Yes.
One of them that I seem to experience when I was on it, I got off of it on my own and then got down on it, but it restricts the swallowing area. And I feel like if you eat something, sometimes it doesn't feel like it goes all over the skin. Is that one of the side effects of that?
It's not the side effects of the reflux, it's more I never heard about that. I never heard about that, but there are other conditions not related, not to the PPIs and not to the reflux disease that may cause it. So I don't know when you had your last upper endoscopy. Okay, if they've taken biopsies or not from the esophagus, those are questions. Henderson? Yeah, so I hope he took biopsies from the esophagus. It helps us to rule out any kind of other diseases that may cause this, feeling that you have. But that's what I will do, not more than that. I never heard about PPIs that cause.
I've been on PPI for years, and I just got off of it on my own. Because I've seen so many negative
Yeah.
reports for renal failure, several things that come up with that. So I kind of got off of it on my own. When I got off of it on my own, it eliminated the cough, it eliminated the swallowing issues.
So chronic cough can.
I never have heartburn.
So why you are on PPIs?
Because I have a Barretts esophagus.
Okay.
And we just found that just a couple of years ago, 3 or 4 years ago, even though I've had the thing, that's how long I've had it, when I had the first one done several years ago. All right, well I never felt the heartburn, I know I have to have it because I have the GE. That being said, when they put me on that PPI, I've been on it about 80, 90 years. And I've always had this cough and this kind of a swallowing issue while I've been on it.
So cough can be a side effect of PPIs, okay? But about the swallowing issues, I never heard about that. But you are the one of those that I just said that 50% of the patients with Barrett's esophagus never experienced any reflux. So that's.
Yeah, well, he's checked me for everything under the sun. So I'm good for that, I guess. But like you said, and then I worry about the renal failure. My mother was on the omeprazole for years, and that's what she had.
Yeah, but most probably she had diabetes? No. So I don't know if she had uncontrolled blood pressure or other medications she's taking.
She was on omeprazole for 20 years, or however long it had. She's done it for years and years. So, but she did have renal failure, and it started, but nobody ever connected it to the renal failure until just recently.
Yeah, so the main renal failure that you see, if it happens because of the PPIs, will be in the first month or two that you are treating, not like because of 20 years of treatment, okay? So I don't know, I don't know all the history to say.
These questions because I know that I need to be on something. Is there anything other than the PPI that you can take for that? Or are there less doses than 20 milligrams?
So, one of the things that we can think about is when a patient has Barrett's esophagus, if you got any kind of treatment, okay, for the Barrett's esophagus, and we eliminated the Barrett's esophagus, is to do one of those kind of procedures to lower the use of PPIs. Yeah.
I didn't understand that also. What I'm trying to do is figure out how to proceed with the PPI.
Yeah.
I know that I'm told that I need it.
Yes.
All right, but then besides, if I have a swelling of the inside of the mouth, and in the mornings when I get up, my eyes are kind of swollen and stuff. And I get over it, but I have the cough that goes with it, and that is annoying, that it's not fatal. But I'm wondering, and I'm on a 20 milligram.
Pantoprazole.
Is there a less amount that I could take? I was on omeprazole when they put me on this, I was on 20, and they put me on the kind of, I don't know if they're equivalent, like.
Pantoprazole can be 40.
Equal, like
Yeah.
it's double my amount doing that. But, I don't know exactly what I'm trying to ask.
Yeah.
I'm trying to find out if I know I need to stay on it. But, is there any other treatment that I can take? Or another type of medication that I can take besides these?
No. Medications wise, no. Just PPIs. Yeah. Yes, ma'am. So it can, most probably the belching is caused by, a lot of air within the GI system. There are a lot of conditions that may cause that, in between bacterial overgrowth in the small bowel that may cause that. So I think, and it can be also related to some sphincter loose issues. So I think she should be seen by a GI physician, just to understand a little bit better the complaints, and then maybe to proceed with at least 1 or 2 tests to rule out, you know, the bacterial overgrowth, or to do the manometry to see the pressures of the muscles. So. Yeah, so that's something that should be explored a little bit more. Okay? Thank you very much.